Today, I'm joined by Dr. James Cash, an orthopedic surgeon who's left a significant mark on Tulsa's healthcare landscape and has also been a relentless advocate for price transparency in physician-owned hospitals. As one of the founders of Oklahoma Surgical Hospital, Dr. Cash has seen firsthand the obstacles and opportunities that come with making healthcare more transparent and accessible. From his journey into medicine to navigating the complexities of hospital ownership, as well as the legislative environment, Dr. Cash has prioritized patient care and affordability. Now retired, he brings a wealth of insight into the evolution of healthcare and what's next in his advocacy journey. And you've done this for a long time. Like when we met maybe a year ago or so, you told me, hey, listen, I've been working with the Oklahoma legislature for as long as I can remember.
7 years now.
Yeah.
So 7 years we've been working with the Oklahoma legislature, trying to get legislation passed that will mandate that all healthcare providers have to provide cash pay price transparency for their most commonly performed procedures. That started 7 years ago. It took us 3 years to get it through the legislature.
Mm-hmm.
But unfortunately, nobody followed that law once it passed.
Yeah.
So what we did, we worked for another 3 years to get a penalty phase to that bill.
Okay.
Saying that if you didn't comply with providing cash pay price transparency, then there was a penalty to that. And that just passed last summer.
Wow. So when does that go in effect?
Went in effect 4 days ago.
4 days ago?
Today's the 5th, right? So
yeah.
Today's the 6th, 5 days ago, November 1st.
So not only do physicians have to provide, or a physician office or a hospital have to provide a good faith estimate, but they also have to provide cash pay prices in Oklahoma.
Right. So Oklahoma is kind of the leader in this.
Yes.
In that not only physicians and hospitals, but pharmacists, physical therapists, mental health professionals, everybody in the healthcare profession has to provide their most commonly performed procedures or tests or exams, cash pay pricing, either on their website or available in their office. And now if they don't do that, and they turn somebody over to collections, this is the penalty phase that went into effect starting this year. If they don't do that and they go to turn somebody to collections, they can't actually collect a debt from that patient if they don't show that they participated in that price transparency law.
That's really interesting. I've been doing this for, let's call it close to 30 years. And I got sent to Works and Lents by St. Francis, one of the oligopolies here in town. Mm-hmm. My daughter had a procedure that I paid for in advance. Like I called St. Francis, paid for it in advance, but they sent the bill to my kids in my kid's name. Now at the time she was 4. And then I got a collections notice and I called, and then I had to prove, right? I had to show my single case agreement. I had to fax it to their billing office and show that I'd paid it. And then I had to show my return check where I did pay it and it was cashed by them. And that whole process took probably 2 months. And the whole time I'm getting letters from Works and Lents. It was a joy to move to Oklahoma, I can tell you. Okay. So what was kind of the impetus for you to start down the price transparency pathway? Like, what was it? I mean, I've been around a lot of physicians for a long time. You struck me as exceptional because you thought, like our first conversation was all about, hey, how do we help the patients? How do we make it more affordable and accessible? So what was it? I mean, it's like you, Keith Smith, and 4 others in the entire state that are proactively working on this. So what was it for you that kind of got you there?
Well, I think for me, my path was I'm from Oklahoma originally. I was born in Tulsa, came back here after all my medical training to start in private practice. And like most physicians, when you start in private practice, you really don't know anything about the business side of medicine because they don't teach anything about the business side of medicine in medical school, at least not when I was in medical school. I don't think much now either.
No,
right?
No, there's not.
So you sort of learn by osmosis in regards to business side and the pricing and the cost. And what I started to realize pretty quickly was that when patients would ask me, well, how much was this going to cost? I, for the most part, said, I have no idea.
About it.
You'll have to ask my business people here in my office.
Yeah.
And that felt uncomfortable because as a physician, that's what I felt like I should know. Because if I'm my patient's advocate, which I'm supposed to be as a physician, I should be their advocate not only in getting them better health-wise, but also not driving them into bankruptcy or
Right.
having them have a bill that's ridiculous or charging usurious prices for something that I think should cost way less. And so I think in my medical practice, I started getting interested in it. And then when we went from a medical practice to eventually building our own hospital, and I got very interested in that, was involved in the development of that, that's where pricing became much more interesting to me, in that I knew we could affect pricing in a way with a new facility in a way that hadn't been done in the past.
Kind of tell me what the moment was, or one of the moments where you realized, like, I really need to know the price. Was it patients asking and you were like, I know my pro fee, but I really don't know what the rest is?
That's it. When patients ask you what's going on with my health situation, part of the health situation is the cost of it.
Sure.
It should be.
Right.
But unfortunately, for most physicians, they feel like that's not my bailiwick. I'm really not interested in that. I don't have time for that. It's too complicated. I want to know. Well, I wanted to know. I wanted to be able to tell my patients. Then when I started to look into it, I realized the price discrepancy of what they could pay depending on what I suggested or which direction I drove them in as far as what their healthcare was going to be was vastly different. So I could sort of help them significantly with negotiating their healthcare situation if I knew what the pricing was, because I could help them much more effectively. So that's where I sort of looked into it more and demanded for myself that I know what the pricing was, so I didn't put somebody in a difficult situation that was untenable for them.
So, because most people just don't know. Most people don't know the difference between a professional fee and a facility fee. And so kind of explain that piece.
So when you go in to see a healthcare provider, you oftentimes will get several bills, and particularly if you have a engagement in a hospital facility. So let's say you go and you have a procedure done at the hospital or an ambulatory surgery center, or even a doctor's office that's affiliated with one of those things.
Yeah, with a hospital.
Right. When you have that procedure, you're going to eventually get a bill, possibly for 3 different things. You're going to get a bill for seeing the physician or the healthcare provider.
Mm-hmm.
You're going to get a separate bill for being in the building.
That's right.
Because the building has expenses. And in our healthcare system here in the United States, that building gets to charge you for those expenses.
That's right.
And then you're also going to possibly get a bill for any ancillary healthcare professional that takes care of you. For instance, possibly an anesthesiologist or a physical therapist or a respiratory therapist or something like that. So you could end up with a very small, what you think is a small and short encounter, and you could get 3, possibly 4 bills.
4 bills, yeah. And then how do the implants work? Is that another separate bill?
It really depends on the facility and the agreement that you have with that healthcare professional and the institution that you go to. So it's so incredibly complex. And if you don't ask the questions before you consume the good,
right,
you have no idea how much it's.
Is this one of the reasons people push back on us for price transparency? Is because they say it's too complex?
You mean pushback is not wanting to know, or just saying, I just don't want to even know about the cost? Or?
No, I think pushback, I get pushback from physicians in general or insurance people because they say, well, these prices aren't actionable, right? You just know the facility fee. What's that going to do for me? Just having price transparency isn't good enough. I need an actionable price. I need a price somebody can act on.
So if somebody's looking for the overall price of what it's going to cost from soup to nuts, from the time you start your healthcare engagement until you end your healthcare engagement, that's really complicated.
Yes.
Because of all those things we just talked about, the 4 different bills that you might get, the ongoing care that you might get. And that's where I know you've been involved with bundled pricing, why that's such an attractive idea to so many people out there, particularly employers or self-employed or something like that, because they want to have control over the costs. And if you don't have control over the costs, they could get out of control.
Yes.
Integrity, innovation, action. PHA isn't just talking about change, we're fighting for it. From new healthcare models to collaborations prioritizing patients, we're ensuring the physician's voice is front and center. We're not just physician-led, we're fighting for the future of healthcare. Join the movement with PHA. Go to physicianled.com for more information. Physicians, it's time to take back healthcare.
And so, like, when we talk about transparent prices and the 108 prices you mentioned a minute ago, are those like grouped together? Are they bundles? Or if I look and see a lab, am I also going to pay like a lab draw fee?
So that's, I think, one currently unfortunate thing about the site is it does not go into that.
Okay.
This, I wanted to make it as simple as possible.
Sure.
Be able to have people get into the system and at least start asking the questions. Okay.
Yes.
Gosh, there's this much of a difference in just that procedure or that test
Yes.
or that exam. I wonder what else is involved. And we have disclaimers all over the site saying, look, this is only the cash pay price for this specific procedure, test, or exam. There could be other charges as well.
Mhm.
Please talk to your healthcare professional about what those charges might be.
Look, I'll take anything.
Right.
I'm like, I'll take any help I can get. Right. And so one of the things I've learned is when we first started working in transparency was we got all these great prices from these labs. And then our customers started coming to us and saying, hey, I got a bill for a lab draw. And I was like, well, like, I've been around healthcare 20 years at the time. I was like, what do you mean? And they're like, oh, you didn't put that in the agreement. So then, a big, large network of labs charged us an additional $7. So I lost a lot of money because, of course, we were going to pay it for the patients. It wasn't going to let them pay for something that we'd promised them. What kind of hidden fees? You mentioned CTs. I mean, I want to say there's 60 to 80 million CTs performed in any given year. What variances do you see there? I mean, I know you talk about price variance, but what variances do you see in the price, like the total price and then the pro fee versus the facility fee? Like, what's a read? What's contrast sometimes included? Like, kind of talk to me about that a little bit.
Again, the answer to that is based totally on the facility that provides that service. So some facilities will bundle or put together those two fees, the professional fee, which means what the healthcare provider that reads the scan, that gives the written report, that could be one fee. And then there's the procedural fee, which is actually going through the machine fee. So that could be two separate fees or it could be bundled together. Most of the time with cash pay pricing or bundled pricing, those two are put together.
Yeah.
So for CTs, for MRIs, for most of those tests, those two fees are put together. But you're not for sure that that's the case unless you ask the question.
Unless you ask. Yeah.
I mean, this is what's crazy about American healthcare now, and the ongoing healthcare that's been our way of delivering services for all these years, is that the consumer has no clue how much something costs until after they already consume it. It's pretty much the only industry in America where that's the case, where you have no idea how much something costs until after you consume it. And then you're not going to know the cost until maybe 6 or 8 weeks afterwards. It's crazy. What other industry would allow that to happen? There aren't any.
No.
And people don't seem to be outraged by it, except for people like us.
Are we the only two?
And that's why we're trying to convince people why they should be outraged by it. You would think that the people that are paying for all this would be outraged by it.
Do you think so we got some stats from the Kaiser Family Foundation recently, like in the last 2 weeks, and it says now nearly 89% of individuals with high deductible health plans, right, do not reach their deductibles or their max out of pocket, right? And then the other interesting stat was there's almost 80 million people on high deductible health plans. Do you think, if you were talking to yourself 20 years ago, do you think, hey, now there's an actual market for cash priced healthcare under a deductible? Let's call it $6,000 or $7,000.
Well, I think there's been a market for that for a long time.
Yeah.
I think the key is educating people, because now the deductibles have started going up because healthcare plans are so expensive. It used to be a high deductible plan. Very few people had them.
That's right.
Because there were people didn't want to take that risk.
That's right.
But now I think a high deductible plan is categorized as over $2,000 deductible. And so even most companies now have that option for a higher deductible, and most people are choosing it because the lower deductible is so expensive now, people just can't afford it.
Can't afford it.
People are priced out of it. Now what has to happen is patients have to be educated that, hey, 89% of people aren't reaching that deductible. If you went for cash pay pricing, which my family, I don't know about you, but my family, we've been doing that with our family, I'd say for at least 10 years.
Yeah.
We pay now we're fortunate, very fortunate that we're healthy. Even if we do have to have a procedure, we generally don't get to our deductible, and it's an individual deductible plus family deductible. So we almost never reach those. So when we pay for everything with cash, we save thousands of dollars every year. And we have a health savings account. And so we take the monies to pay cash from that and just with a credit card. And I've trained everybody in my family now to say, hey, don't consume anything until you ask. We're paying with cash. We're not going through our insurance. And we save thousands of dollars every year. The key is educating people that that's a possibility. And it's also a bit of a risk.
Sure.
Because particularly in states that don't have the ability to put that deductible or put that cash pay price, that payment towards your deductible, you could lose double that year.
Sure.
So you could lose your deductible plus what you paid in cash.
Yeah.
And I would tell you in 10 years,
That hasn't happened.
It hasn't happened to us.
No.
So if you're healthy or don't consume much healthcare, it's a great way to save money.
It's interesting. I get that pushback a lot on, well, Dutch, they wouldn't apply it to my deductible. But what happens then is then I like personally get on the phone with people because then I'm annoyed. And then all of a sudden it does happen.
Because they understand it.
Because then I'm talking to someone on the 1-800 number and I know how to talk to them and I know what to say, which gives me an unfair advantage perhaps. But then it does work. So I'm like you, I've never had it not happen. I've always had it applied to the deductible no matter where we are. Now, the other thing is, I don't know, this has probably happened to me 10 or 12 years ago when I was still living in New York City. What happened was they applied it towards my, they said, okay, well, you're out of network. And so we'll still apply it to your deductible, but it'll be a 50-50 deal, right? Because out of network, they always stick you out. And so, but I thought, well, okay, fine, at least it's something, right? It's not nothing. But it does require a lot of education.
So you'll have to let me know about the states that have gotten that legislation passed.
Okay, so right now it's just Tennessee and Texas.
Okay.
Now, what I don't think 99% of Americans know, because I'm such a fierce, on one side, I hate the No Surprises Act, right? And I'm beating down the doors of these legislators like, you're really hurting physicians. But the side that I did like was the good faith estimate. And so now we're trying to teach consumers, hey, if you live in a state that's not Texas or Tennessee, what you can do is you can ask for a good faith estimate. That good faith estimate has to be within $400. If you have cataracts, and let's say the good faith estimate comes in at $3,000, is that a good price? Yeah, could be.
Luckily, I'm
right
not there yet. I don't know.
No, I was thinking about all the prices on the cataracts that we've seen. And then let's say it comes in at $4,000, but they gave me a GFE. I'm only responsible to pay $3,400. They have to eat the other $600. Now that's a federal regulation. And again, most offices don't know it. So literally, I've had to coach people no, you have to walk in and you have to show them, or you have to call them back, and then you have to fax it over. But once you do that, then the process is solved. It's just kind of sad that you need to do that. Let's back up just a little because I love your website. I love the passion for all of it. And all of a sudden, it's obviously all driven by wanting to be an exceptional caretaker of physicians or of patients. But tell us a little bit about your journey into private practice. And then how did you end up building I find these stories the most how does a doc go, I think I'll build a hospital? Oh, okay. Normal people don't think that way. So what was it that you thought, okay, I think that might be the road we go down?
So I started in Tulsa in 1989 after my medical training. I wanted to come back to my hometown and practice, joined a small group of orthopedic surgeons. There were 5 people in the group. I was the 6th, and had a great private practice here. And we worked at one of the big community hospitals here in town.
Okay.
did probably 90% of my work at that one community hospital, 10% at a couple other community hospitals, trying to get my practice growing. My practice grew. That group of 6 eventually merged with another group of 5. We got a little bit bigger. But what I realized was that as time passed and doing procedures here, orthopedics is a very technical and tech-driven subspecialty. We use lots of equipment. The technology changes several times a year. If you stay up on the technology, you need new equipment all the time, and you need subspecialized equipment and subspecialized nursing. And what our group, that eventually became about 10 or 12 docs, realizes that the facilities where we were working were not willing to keep up with the technologic needs that we needed as physicians to stay on the cutting edge.
Really?
In other words, they were saying, yeah, we'd like to bring in more equipment for you to be able to do these procedures, but our equipment room's really full right now, and you're going to have to get rid of some of the older equipment that isn't used as much but still being used if you want to bring in anything new. And oh, by the way, we're having some nursing shortage, so we're moving some nurses around. So on the orthopedic floor, instead of having just orthopedic nurses, subspecialized orthopedic nurses on the floor and in the operating room, we're going to have obstetric nurses. We're going to have ENT nurses because we just can't hire enough orthopedic nurses, and we're going to move things around. And so we were finding,
You thought that was strange.
well, it wasn't the way I was used to practicing medicine, or the way I wanted to practice medicine, or the way our patients deserve to have care. So we wanted cutting edge care, and we wanted the best nursing available to be able to care for our patients postoperatively. And that wasn't happening. And the facilities weren't willing to help us get there and do the things we needed to do to what we thought was provide the best care for our patients. So we started having talks with the administration at the hospitals saying, look, we need these things to be able to practice the best medicine we can. We'll do whatever we need to do. We'll sacrifice. We'll put in our own dollars. We'll joint venture with you to get these things. If you don't want to spend the money to do it, we'll put our money in as well. They sort of dragged the talks out. We're sort of unwilling to do it. We eventually went to them and said, look, let's do a new idea. Let's have an orthopedic hospital.
Yeah.
Instead of just having a small section of one of the floors where ENT nurses take care of the orthopedic patients, let's just have a dedicated orthopedic hospital. We'll joint venture with you. We'll put our dollars in. We'll do it together.
And like, how long is this process all take?
This was taking over 3 to 4 years.
Oh, wow. Okay.
This was basically the slow no.
Yeah.
Yes, let's have another meeting. We'll meet again next month. We'll meet again next quarter. Yes, we kind of have a framework. Let's get in the lawyers. Let's do this. Let's do that. It was the slow no. So finally, after several years, there were a couple things that happened where the group sort of said, look, if this doesn't happen now, it's never going to happen. It didn't happen. And so we said, okay, we're going to do this on our own. And so I went home to my wife one day and I said, look, honey, we want to develop our own facility because the hospitals aren't giving us what we need, but it's going to have to be physician-led. Because our other option was to bring in corporate managers and do it for us. We didn't really want to do that. I thought we needed to do it on our own. We need to have control of it ourselves.
Yeah.
We didn't want somebody else having control of what happened for us. And so I said, I'm going to take some time out of my practice, cut my practice life down, work on getting a hospital built. She said, you're unhappy where you are now, go for it.
Wow. And what was that so how long did that take? So you're kind of going half-time or three-quarter time?
I went half-time in my practice, and the other half was put into finding a site, hiring staff, getting things built, getting regulations taken care of, making sure and raising the money from the physicians. We funded ourselves. It was basically, it was our group, another group of orthopedists. So it was 16 orthopedic surgeons, 2 neurosurgeons, and the anesthesia group that was going to work with us. So it was 100% physician owned, driven, funded.
And what year is this?
I started the process in 1999, and we opened in August of 2001.
This is like book-worthy stuff. I mean, this is a long process. Because, people hear...
Might be read by my family and maybe a couple others.
People hear this and they go, oh my gosh, that's so much work.
Well, it wasn't just us. This was happening all over the
Country, sure.
This was happening all over the country. And frankly, it scared the heck out of community hospitals and the American Hospital Association, who fought back desperately to prevent this from happening. And the Oklahoma Hospital Association.
Why would the Oklahoma Hospital Association or the American Hospital Association, why would they care what a bunch of orthopedic guys are doing?
Money.
Is that really what it comes down to?
Well, they were worried about competition.
Right.
They didn't want to have happen to the hospital group or the hospital association and the hospital industry what happened to the ambulatory surgery industry.
Yeah.
Which is physicians started developing their own small ambulatory surgery centers, and they opened thousands of them all over the United States and drew business from the hospitals and took care of patients in a more efficient, more economical way. And they didn't want that to happen with the hospital industry.
I mean, but your prices were lower, your quality's higher. Like, how does a hospital association or a hospital leader, how do they not like that? I mean, isn't everybody in it for patient care?
That's a loaded question. I'm going to assume that everybody's in it for patient care.
I mean, that's the assumption I work on.
But if you run a business and you're being graded by how much that business is generating in profits, and you see another competitor coming to town to draw some of those profits away, you're going to probably do something to try and prevent that from happening. If you can, they have a lot of power. The hospital association, both nationally and statewide, has a lot of power.
Well, they managed to ban physician-owned hospitals, get a moratorium.
Yeah. They managed to ban the new
ones.
Development of
Yes.
Old ones that had already been present were grandfathered in.
Do you remember like how many that was? I mean, you were one, obviously.
A little over 100.
A little over 100.
I think there were about 110 physician-owned facilities at that time. The bill passed. It was part of the Affordable Care Act.
That's right.
The bill passed in 2009 and went into effect in 2010.
That's right.
So
HR 6001. I've read it way too many times. I don't like it. What do you think? We're kind of being hypothetical here. What do you think it did for the industry? Do you think premiums would be as high as they are if we had more supply from physician-led care, or physicians were still allowed to build and own hospitals? Do you think we'd have the challenges we have in rural America if doctors could still band together and own hospitals?
I would like to think that is true, that if the Affordable Care Act provision that prevented physician-owned hospitals were either rescinded. I know there are bills that are working their way through Congress now to try and affect the ability of physicians to own rural hospitals.
That's right.
I would like to think that would happen because competition usually makes people better and oftentimes will drive down prices. I'm concerned, however, that with the American healthcare system, that's not going to happen as far as prices being driven down, because it's a profit-driven industry.
Yep.
Where everybody within the system, including physicians, were at blame just as much as everybody else.
Yep.
Have no incentive to drive down pricing.
This is why I like talking to you, though, because you're honest about it. I think if we don't have good data and we don't have good facts, then we can't make good solutions, right? I mean, I think I'm a pretty fierce physician-led healthcare advocate, but I see the weaknesses, right? And some people don't like them when we bring them up. But I'm like, well, the more you know about the weaknesses of yourself, the better you can change, right? The more good you can do. We do have to self-identify and say, can we be introspective for a minute and see where we're to blame? I don't understand why the moratorium exists anymore. And then I go to Washington, D.C., and I see the same, call it 75 to 100 physicians every year showing up. I see the same ones in the state legislatures going to fight certificate of need in their state. And then we get lots of rah, rah, rah on social media like, yeah, this, we've got to knock down Con, or we've got to get rid of the moratorium, or, the No Surprises Act really hurt me. But there's no action. What help, if any, did you get from other docs on your Oklahoma legislation?
We got a lot of help. I mean,
good.
Our county, the Tulsa County Medical Society supported us. The Oklahoma State Medical Association supported us. We got almost no pushback from physicians, except we got some pushback on the penalty phase from some rural physicians. Got some pushback on the initial phase of implementation from the rural physicians who said, well, we don't have a website.
Mm-hmm.
We don't want to have a website, and we don't want to go through more regulation of putting our pricing out there. So there was a little bit of pushback there, but not much.
Not much.
Most of the pushback came from the hospitals and from the insurance companies.
Oh, that's really good to hear.
Savos Health is today's sponsor, bringing you the largest marketplace of affordable cash prices for medical care such as imaging, labs, and procedures. Savos Connect makes it easy for patients and physicians to offer bundled pricing, simple scheduling, and immediate cash payment. It's perfect for anyone looking to cut out traditional networks and pay directly. Visit Savos Health's website at savos.com and discover how cash pay can transform your healthcare experience.
You know, one of the things, so I've been in Oklahoma now 4 years. October was year 4. I don't know if Oklahoma was happy to have me. But I see a very, having lived in the, 2 of the largest cities in the country, and those are coastal elite cities where I hear about flyover country all the time. I have to say one of the big conclusions that I've come to is Oklahoma hospitals, mostly the physician-owned ones, because there's a bunch here, there's more than 10, and physicians here are more progressive than in most other states. Why do you think that is? If you had to suppose, like, why are we so forward on these disruptive innovation type things? Why do you think that is?
Well, I don't think we're any more so than other physicians around the country, but I think our laws were a good situation for us to be active and proactive. So we didn't have, it was a non-certificate of need state. That was number one. So certificate of need states had no chance of getting hospitals built because the hospital associations were so strong in every state and nationally that if you were a certificate of need state, you were not going to get a hospital built as a physician-owned hospital. So that's why Texas, Oklahoma
are so strong.
Right. Yeah. But what worries me is that even with this new legislation passing, because there's so few independent physicians now compared to what it was 20 years ago before the ACA passed, or before we actually built our hospital, physicians are less inclined to engage on the business side and to be concerned about pricing at all. Because if you work for a hospital system or a hospital, you want to go to work, you want to take care of your patients, and then you go home. You don't worry about the pricing stuff. You don't worry about costs. You don't worry about whether the patient's getting a bill or not, or how much that bill is. You just want to take care of your patient and go home. I think the part of taking care of that patient is making sure that patient doesn't go bankrupt.
That's right.
Or doesn't get a bill that's a crazy high number. So because now only 20% of the physicians that finish their training go into independent practice. 80% are going to work for some facility, either a hospital or a hospital system or corporation. That was flipped 30 years ago.
That's right. 100%.
So 80% of physicians 30 years ago, they came out were independent.
What do you think we can do? What are just some top of mind thoughts that you go, if we could do these things or work on these things, this may right the ship?
Well, I think it's going to take courage and leadership nationally and statewide. There's got to be some leader of some state or possibly a national leader that would come up and say, look, the system that we have here isn't working. I mean, U.S. spends almost 20% now of its GDP on health.
It's an insane number.
It's double. Yeah. Double compared to the next industrialized country. Yeah. Right. Switzerland's like 11%. U.S. is almost 20 now. It's crazy. So, and that's coming from your tax dollars that's paying for a lot of that, and from your dollars that you're spending at work. Yeah. Because instead of getting a bigger paycheck, a lot of that paycheck's going to pay for your employer paying for your health care. So some leaders got to sort of get that and say, look, this is not right. There's got to be a better way to do this. And that's, I think, going to have to be.
Do you think that there's a possibility we could build a coalition of physicians to fight back and do it?
Well, traditionally, physicians haven't been engaged too much politically. So I think that's going to be a challenge. So physicians don't engage politically because they feel like, they're already working 60, 70 hours a week.
Sure,
they don't want to put more into going to the legislature. And they've been terrible at giving to PACs. So political action committees get almost no money from physicians. We're some of the worst givers. The lawyers are great at giving. The hospital association is great at giving. Insurance companies great at giving. So where do decisions get made? They get made by how much money you give to political action committees and to the politicians. And physicians are not good at that. So I'm not hopeful that that's going to change anytime soon.
Anything else then that we can do?
Yeah, I think we can convince physicians that there's a reason why they should care about pricing. And that can happen in medical schools.
I love that.
I think economics of healthcare should be part of the curriculum of every medical school in the country.
And what would we teach? And then I think I might have some ideas, so I kind of want to talk about it a little bit more
I think we talk about the stuff that we've talked about today.
today.
You show them comparison pricing in their area where they're in medical school.
Yeah.
What a CT scan comparison cost can be between high and low. And then you show them the percentage of people that are going into bankruptcy because of their medical debt.
Mm-hmm.
And I think physicians would be rightly outraged.
Yes.
But until they know about that, they're not
They can't be
care about it.
Yeah. Is there space, not only in medical school, but also perhaps residency, fellowship? Is there space there for this type of education?
Sure there is, but it depends on what residency you're doing. So if you're doing a residency at an ivory tower institution where the physicians don't know anything about pricing,
Right.
and they're doing research and they're taking care of their patients and they just don't really know about pricing, they're not going to get that information.
Yeah.
But if that's part of the curriculum, which it could be and should be, then they can learn about it. But I think you have to educate the physicians, because physicians in training, they're idealistic when they go in. They don't want to hurt people financially. They don't want to hurt people physically or medically, but they got to know about the financial part that patients can be hurt with too.
What kind of information do you think they need to know? Like, would it be helpful if a radiologist knew, hey, for imaging tests, like this is kind of the space that it runs in? In New York City, an MRI with contrast or with and without contrast might run $800 on a cash pay basis. But with coverage at NYU Langone, it might be $3,800. Like, is that kind of the type of education you're thinking about?
That's exactly right. And that's what we're trying to do with our website.
Yeah.
Is if I can, what I'm working on now is trying to get others interested in the website. There are people out there around the country that are also interested in price transparency. Cynthia Fisher is one with patient rights.
Oh, I love her.
That comes to mind. She's spectacular.
We should say that again, that we love her.
Cynthia Fisher is spectacular. And
That's fantastic.
I've been talking to some of the people in her group about they're interested in what we're doing, and they're also interested in developing what we've got, which is a consumer reports for healthcare. So consumer reports, you want to buy a toaster in America, and you take consumer reports, you have access to consumer reports, you look it up, you find out what the best buy is, or the best one is, and you decide, am I willing to pay up a little bit for the best buy or the best one, or do I want economical and get the best buy? At least you have pricing, you know which one is high quality and how much the prices are.
Yes.
Why don't we have that for healthcare?
I've never understood that. I mean, I come from the banking Wall Street side, and I think, we have buy side analysts, sell side equity analysts. Like, we know everything about one share of stock. I mean, everything. There are 10,000 people that look like me that know everything about the buy side and the sell side. And yet we know nothing about total joints.
Right.
If I ask the average consumer, what's the physician get reimbursed on a Medicare total joint? 1, they don't know what a total joint is. And 2, they don't know what Medicare is. And 3, they have no idea. But you and I know. And I think sharing that information is really, really important. Okay, so tell me one more time what the name of the website is, because I want to make sure the audience gets it so they can support you.
Medpal.health.
Okay.
It's a nonprofit organization, nonprofit site. All information.
That means it's all subsidized by you.
Currently. But I'm looking for partners
Yes.
have the same vision, that want to help spread the word. Because if it's all funded by me, then some people will get some information in Tulsa, Oklahoma, but it's funded by others. We can spread it regionally, statewide, and eventually nationally. I think Cynthia Fisher's vision of having a consumer reports for healthcare is a great one. This would be a great start, at least for cash pay pricing.
Yeah.
And we're looking for other people that might be interested.
How do they reach you? They just go to your website? Is there like an email on there?
There is. An organization that funds the MedPal.health is called Alliance for Medical Price Transparency, AMPT.
Okay.
And there's an email for that, ampt.tulsa@gmail.com.
Perfect. Well, thanks for being with us today.
Dutch, always a pleasure.